Hi, my name is Nicole, and I am a current nursing student at the University of Michigan. Today, I will be presenting a patient to you. Patient is a 20-year-old Caucasian male that is not married. Patient is an engineering student at the University of Michigan and usually receives care from a primary care provider in Port Huron, Michigan. Patient's vital signs were recorded at pulse 65 beats per minute, respiratory rate 16 breaths per minute, blood pressure 118/82, and temperature was not recorded because equipment was not available. Patient's chief complaint is right knee pain. History of present illness. Onset of pain occurred during May of 2014 when patient was running and ran into a bench. Patient's pain is right anterolateral knee pain that runs along the patella. Patient rates pain as a 4 out of 10 while normally standing and performing ADLs. Patient rates pain as a 7 out of 10 at its worst, which occurs during exercise such as running. Patient states pain reaches a 7 out of 10 at least once a week. Patient states that when at rest, pain is a 1 out of 10. Pain is best when patient wakes up in the morning. Patient's pain has been constant since 2014. Patient states that his pain has gotten slightly better and he can stand longer until pain increases. Patient describes pain as constantly aching and throbbing after exercise. Patient states that there was a sharp stabbing pain with initial injury. Aggravating factors include standing for long periods of time, exercising, excessive use, and driving. Relieving factors include rest, ice, use of non-steroidal anti-inflammatory drugs, and sitting. Patient has never seen a doctor for the problem. Patient wore a brace for the first 3 months after the injury, but stopped use because he didn't feel like it was helping. Patient ices knee about once a month when in pain, but is not consistent with this treatment. Patient can function normally with pain and carries out ADLs. Patient believes pain is tendon pain or kneecap hairline fracture. Past health history. Patient had viral meningitis in 2006. Patient fractured fifth metacarpal in 2012. Patient is up to date with his immunizations. Patient has no known allergies. Patient was hospitalized for concussions in 2012 and 2014 and was admitted for 1 night with each visit. Patient was hospitalized in 2006 for 4 nights for meningitis treatment. Patient has had oral surgery for excision of wisdom teeth in 2015. Patient takes ibuprofen as needed, and when needed, patient takes 400 milligrams orally. Functional assessment. Patient reports no drug use or smoking. Patient reports drinking alcohol about 3 drinks a week or about 10 drinks a month. Patient exercises once a week and reports a regular sleep schedule with about 7 hours of sleep a night. Patient drinks an average of 1 caffeinated drink every other day. Patient reports using seatbelt, wearing a helmet, and not texting while driving. Psychosocial assessment. Patient has 2 younger brothers, ages 16 and 18, that both live at home. Patient's parents are married and live together in Port Huron, Michigan. Patient stressors include school, work, and money. Patient works in an automotive factory where hazards include heavy lifting and heavy metals. Patient participates in a yearly physical with family healthcare provider. Family history. Patient's mother is an alcoholic and smoker. She has smoked half a pack of cigarettes a day for 25 years, not including a 15-year break during childbearing of her 3 children. She has smoked for the past 15 years straight and still currently smokes. She has approximately 6 alcoholic drinks each day. Patient's father has broken 59 different bones due to reckless behaviors such as multiple motorcycle accidents. Patient's father shows signs of early dementia. Patient's siblings have no known medical disorders. Patient's maternal grandmother died at age 65 of myocardial infarction due to coronary artery disease. She was overweight and had hypertension and high cholesterol. Patient's maternal grandfather died at age 61 of myocardial infarction due to coronary artery disease. He smoked a cigar once a week, was an alcoholic, was overweight, had hypertension, and high cholesterol. Patient's paternal grandmother died at age 81 of old age. She smoked 3 packs of cigarettes a day for 70 years. Patient's paternal grandfather died at age 90 of complications from dementia. He had high cholesterol, hypertension, and gout. Physical assessment. Due to my patient's pain in his right knee, I assessed the musculoskeletal system in order to assess joint functioning. In addition, due to my patient's chronic knee pain, I chose to assess the neurological system. Review of systems for musculoskeletal system. Patient has pain and morning stiffness in right knee. Patient noted swelling and heat radiation from right knee after excessive use. Patient reported no redness, crepitus, or limitation in range of motion. Patient has no muscle pain, cramping, or weakness. Patient has no current bone pain or deformities. Patient fractured 5th metacarpal in 2012. Patient reports no personal or family history of neuromuscular disorders. Patient reports no deficit in activities of daily life and does not use mobility aids. Patient has occupational hazards of working in a factory that requires intermittent heavy lifting. Patient played lacrosse in high school, which patient identified as a sport with high risk for injury. Patient participates in little regular exercise, but does play the occasional intramural sport. Patient reports no recent weight gain. Patient reports drinking an average of 1 caffeinated beverage every other day and an average of 3 alcoholic beverages a week. Patient reports taking 400 milligrams of ibuprofen orally as needed, but not more than 3 times a day. Physical assessment for musculoskeletal. Patient has symmetrical muscle and bone size and shape. Patient shows no signs of atrophy or hypertrophy. Patient has erect posture and even gait. Patient was assessed for scoliosis by palpating spine, scapula, and iliac crests. Spine is midline with no curvature, and scapula and iliac crest are at symmetrical height. Patient's joints were assessed for range of motion, erythema, inflammation, warmth, pain, and crepitus. Joints assessed included TMJ, neck, shoulders, elbows, wrists, fingers, spine, hip, knees, and ankles. Patient reported pain with circumduction of wrist and pain with flexion of the knee. Patient reported relief of knee pain with extension of the knee. Crepitus was noted in the ankles. No other abnormalities were found. Patient's muscle strength was tested in his deltoids, biceps, triceps, wrists, fingers, hip abductors and adductors, hamstrings, quadriceps, and ankles. All muscles were graded out of 5+. Review of systems for neurological system. Patient reports no unusually severe or frequent headaches. Patient has a history of concussions in 2012 and 2014. Patient has no current head injury. Patient reports no dizziness or vertigo. Patient reports no change in sensory sensations of vision, hearing, smell, taste, or touch. Patient reports no weakness or lack of coordination. Patient reports bilateral tingling in all five digits of the hands. Patient reports no difficulty swallowing or speaking. Patient has history of viral meningitis in 2006. Patient's paternal grandfather had dementia. Physical assessment for neurological system. Patient scored a 29 out of 30 on the mini mental state exam. Patient lost 1 point for the inability to write a grammatically correct sentence, but patient stated this is a normal finding. Patient was alert during the exam. Patient's gait was smooth and coordinated with no shuffling. Patient had steady balance while walking heel to toe. Patient had no excessive swaying or loss of balance during the Romberg test. Patient was assessed for 3 types of upper extremity fine motor skills: finger to nose, finger from nose to examiner's finger, and rapid alternating movement. Patient's upper extremity fine motor movements were smooth and coordinated. Patient was assessed for lower extremity fine motor function by having patient move heel up and down opposite shin. Patient's lower extremity fine motor movements were smooth and coordinated. Patient was able to ID light, painful, and dull sensations bilaterally on the face, upper, and lower extremities. Vibratory sensation was not assessed because a tuning fork was not available. Patient was able to ID objects, discriminate touch, and discriminate location of body parts, demonstrating stereognosis, graphesthesia, and proprioception. Patient's plantar reflex shows no signs of Babinski response. Patient shows no signs of ankylosing. Pertinent System 1. According to the U.S. Surgeon General's report entitled The Health Consequences of Involuntary Exposure to Tobacco Smoke, it is important to assess the patient's respiratory system because of the patient's exposure to secondhand smoke from his mother. The evidence suggests a causal relationship between secondhand smoke exposure and acute respiratory problems, including cough, wheeze, chest tightness, and difficulty breathing among healthy persons. The evidence also suggests a causal relationship between secondhand smoke and chronic respiratory problems, a small decrement in lung function, adult-onset asthma, and risk for chronic obstructive pulmonary disease. Pertinent System 2. According to the Journal of the American Academy of Orthopedic Surgeons article entitled Healing and Repair of Ligament Injuries in the Knee, it is important to assess a patient's peripheral vascular system because of the impact of blood flow on healing injuries. My patient had blunt trauma to the knee that likely affected the internal structure of his knee. With poor circulation to the lower extremities, the creation of new cells can be affected negatively and can prolong the inflammatory phase of healing.